Today we're very proud to have Ruth Wakeman with us, who will share her experience and knowledge around this topic. Ruth worked as a cardiorespiratory physiotherapist for the past 20 plus years, 10 years in the cardiorespiratory pediatric intensive care unit, and then completed a master in advanced clinical practice. She has a special interest in pediatric long-term ventilation for the past 15 years and currently works within the pediatric sleep and ventilation team at the Royal Brompton Hospital in London. So welcome, Ruth, to this webinar. Thank you for accepting our invitation, and I will hand it over for you for the presentation. Thank you.
Thank you very much. Yes, thank you for the invitation, and I'm looking forward to presenting this session today. So for all clinicians working with children and young people on long-term ventilation, the challenges and process behind preparing a child to move from the hospital setting to home will be very familiar. The systems are always different from country to country, so I'm afraid I'm going to present a quite UK-focused perspective on the processes, but the themes for some of the main considerations apply wherever the child is situated. So what I hope to do today is start by just a recap of the population we're talking about. We'll talk a little bit about determining the best time for transition to the home. And then the rest of the session will focus on the two streams of optimising the clinical care so that the child is as stable as possible and readiness for discharge, and the discharge planning processes and the key steps within that. It's important to focus on risk management and then to look at what happens beyond stepping outside of the hospital building. And I look forward to your questions at the end. So it's always good to start with some definitions. Long-term ventilation can be defined as provision of mechanical ventilation for at least 6 hours per day for more than at least a 3-week period. And this encompasses long-term non-invasive ventilation, but also invasive ventilation via tracheostomy. And so predominantly for the purposes of this talk, we're talking about non-invasive ventilation more than CPAP, which tend to be the more complex of the discharges. But again, most of the principles discussed apply whether it's ventilatory support or CPAP. So I'm just going to recap briefly on sort of changes in the population. And there are a lot of good prevalence studies out now to sort of demonstrate the change in population that we're all very familiar with if we work in this patient group. So I've cited just a couple of studies there. Whatever studies you look at, there's a very definite sort of trend in the numbers of patients being seen. Back in the late 90s, early 2000s, the numbers were a lot smaller than now. And so all of the studies that we look at will see that rapid growth in overall population for children supported on ventilation. And what we also see from quite a few of the studies is that the proportion that require tracheostomy or invasive ventilatory support is to some extent plateauing, and the bigger increase is in those on non-invasive ventilation. Some of the studies give a little bit more sort of outcome data, and as you can see here, I've sort of quoted 95% survival. In a proportion, non-invasive ventilation will be discontinued. In some others, the patient improves, and in others, there's a decision made to stop therapy or the child passes away. What's also noted from the studies, as we're all very aware of, is the increasing complexity of a lot of the children we're supporting with ventilation. So just to present some of the UK data, this is from Nikki Barker et al. And the recent reporting of their data collection from 2019. And if you look at the bar charts on the left-hand side, you can see that rapid growth in the total population of children on long-term ventilation in the bottom bar charts. The blue one being back in the late 1990s and grey up to sort of more recent times. And you can see that the most rapid growth, again, is in that non-invasive ventilation population, but in all types, the total is increasing. Looking on the right-hand side, it just demonstrates that the majority of these children are managed in the home. 95% of the children within this this sort of review of the prevalence in the UK were managed in the home at the time. There's a much smaller proportion who are in hospital or in transitional units, and some placed within sort of rehab and hospice settings. And I'm just using this to sort of demonstrate the fact that children, whether they're non-invasively ventilated or tracheostomy ventilated, their destination at discharge from the hospital can vary. The vast majority will be discharged to the home, mostly for active management, but in some cases for ongoing palliative care. There's a small proportion that we discharge to a residential placement or a long-term facility. And then there's always that proportion that are in hospital in the process of getting ready to get home, or may never become stable enough to be managed in a community setting, and those also in hospital that go down a palliative care support route. And often in these children, they might move between groups. The tracheostomy ventilated children might transition to NIV later in life. So there's a lot of movement within that, and within that the planning has to change a little bit. So for the purposes of this talk, we're talking largely about a complex discharge. And as I said, some of the themes apply to both. But as we know, there's a big spectrum of the patients that we're supporting. On the one side, on the left-hand side, we've got a tracheostomy ventilated patient or a very complex NIV patient who might be quite dependent in the home beyond nocturnal, and in some cases 24-hour use, and we'll discuss that further. These patients very much need an individualised approach, and they need very careful decision making about their about going down the ventilatory support route. And these are the patients that have quite a protracted hospital stay whilst they are stabilised, but also whilst everything is put in place to make it a safe transition to the home. Often a lot of complex comorbidities and a lot of teams and specialities involved. On the flip side of that, there's also an increasing number of patients who are supported with just nocturnal, non-invasive ventilation. And in some instances, it might be appropriate not even to start them off in the hospital setting. It may be possible to establish them on support at home or in an outpatient setting, providing you've got a good process for that. And this process obviously is much quicker. The same principles will apply, but it can be in a much more sort of condensed form. You know, maybe with some sort of preparation before they come in to ensure that the learning works well. And we can talk a little bit more about that further on. But largely what we're going to discuss today is the sort of slightly more complex end of that. And then it's easier to sort of reduce that when you're talking about a quick transition onto support. So there's quite a few prevalence studies. There's relatively less evidence to support the decision making around specifics of setting a child up for home discharge with a complex LTV package. But there are very good sort of consensus documents and guidance from all the major countries, and they prove to be very helpful resources. Both the Canadian Thoracic Society, UK guidelines, American Thoracic Society and Australian, all very good resources to refer to. I think what there is consensus about is what we're generally aiming to get to in point of stability from a clinical point of view, to be confident that a child is ready to go home. So we obviously want that child to be medically stable unless they're going down a palliative care pathway. So the health conditions that they have need to be relatively well controlled and can be supported in a community setting. It's essential that they have a stable airway and a stable oxygen requirement. It becomes much harder to manage in community when there are significant fluctuations in oxygen requirement, or if their oxygen requirement is too high. It's not a hard and fast rule, but generally we're looking to have an FiO2 of less than 0.4 at discharge. Stable ventilator settings are really important, so a well-controlled carbon dioxide and stable settings, so not frequent changes, so that they can sort of we can take that out of the equation in terms of things that the care team at home are manipulating. And really importantly, growth. You know, we want children to grow and develop. So if we're supporting them well from a ventilatory point of view and their health conditions are well controlled, then we would expect to see growth and development appropriate to their underlying conditions. The other key factors in home discharge in terms of deciding on readiness are to make sure, obviously, that the family and carers fully understand the long-term prognosis, they're fully aware of the risks and the support strategies in place, and they are willing to meet those long-term needs. And that's a big ask, and it requires a lot of understanding and a lot of two-way conversations between families and the teams to sort of get a grasp of what things are really like at home, and to have a good impression of whether that's going to be manageable or not. And obviously a safe and supported process, and we'll talk about that a lot more later. So I'm just going to, if we're talking about the more complex ones, I'm just going to touch on some of the key considerations that help us make sure that we have a clinically stable child ready for home discharge when everything's in place. So for those that are tracheostomized for their long-term ventilation, then of course it's important that they have a relatively established stoma, that's free from infection. And we want to make sure that the tracheostomy size is appropriate. So we're balancing, it's that trade-off between good gas exchange by not having excessive leaks so that they're well ventilated, but ideally for the majority of patients, allowing enough leak for communication and vocalization. It's so important from a quality of life point of view and from a family well-being point of view. Sometimes we use cuff tracheostomies for these children if we need to gain better control of their ventilation and minimise the leak, and or in the situation where children have significant bulbar palsy or issues managing their upper airway secretions, and making sure we're on top of that sort of risk of aspiration from above is again really important to try and get a nice stable footing before we discharge them home. On the flip side, if they are supported on non-invasive ventilation, then as we're all aware, the interface fit is absolutely crucial. So making sure that we have a good fit, not only for comfort and adherence, but also from the perspective of gas exchange and minimising leaks. And we're needing long-term adherence, so we need a mask that fits well and minimises damages to the skin and affects skin integrity. And often for the children that are a little bit more dependent, that might be a range of masks that they're trained up in using, so they can alternate between a few to sort of anticipate problems before they kick in too much. Obviously, the type of interface needs quite a lot of consideration, and it's always quite an individualised decision based on the patient's background. So moving on from airway, how do we get the child sort of stable on a portable device for transition to home? So there's a lot to consider. It's very much team dependent. There's a lot of factors feeding into what ventilator is selected for use in the home. But I think over the last 10 years, certainly there's been a great improvement in the technology that's available for young children and those that are more dependent. So teams are weighing up factors such as the weight of the child, because that obviously feeds into the sort of trigger sensitivity and the appropriateness of the device that's used. Considerations around the child's level of dependence, because we would select a different device for those that are lacking in underlying respiratory drive or are very intolerant of being disconnected from the ventilator, versus a more nocturnal device where they have where they are using it for health optimization, I guess, rather than being fully dependent on it. The different ventilators afford different modes, and that's often a consideration as well. Oxygen requirement. So maybe if we take the example of an ex-preterm infant that has a significant oxygen requirement and we're transitioning to home, then being able to monitor the FiO2 through the device may be a consideration for teams. And this all feeds into the decision making of what's right in that individual situation. Alarm options we'll talk about further later, but very important to make sure that we can set alarms safely so that they will help us identify issues, but not excessively alarm to sort of cause issues in the home and breed familiarity and lack of response to them. And I think teams also really value the sort of support around a ventilator that they choose to use in these more complex children. So what is the level of servicing, support and call out arrangements so that we can ensure as they move into the home that if something was to become a problem with the ventilator, there would be sort of rapid and appropriate sort of support with that. Some of the devices we can factor in monitoring, depending on whether the child is using the ventilator all of the time or will be off some of the time, then there's different sort of pros and cons to that. Expertise of the team, we all are familiar with devices a little bit more, and we need to think about the teams we're training up, but also as a hospital, which devices we're using, and cost is a factor as well in this day and age. So it's always a balance up between those factors, depending on the child that we're presented with. So moving on, when we're looking at stabilising them for going home on support, we need to sort of think about how much time they are on ventilatory support versus how much time they can be off. If they're tracheostomy ventilated, then that is to some extent less of an issue, but for the children who are non-invasively ventilated, we want to ensure they're stable enough to tolerate some time off so that, again, their skin can have a rest, and from a quality of life point of view, they're able to interact and go about their daily life sufficiently. And I think it's really important as they move to the discharge home that teams are really clear about the minimum and maximum expectations of how much time they will be on their support, and that families know that if they are using their ventilator more than that, then there needs to be another sort of dialogue about what's going on, and we sort of revisit the support we're providing to the child and whether the home is the right place. Clear communication sort of runs through the whole of this. So whilst we're stabilising them for home, there's probably a phase while we're weaning their time off support during the day. And it's really important within our team that we're very clear about the direction of travel with weaning, and we put that within a daily routine that factors in all the other things that the child's doing. We always try and set up sort of unwell ventilator settings as well, so that when a child is unwell at home, there's a little bit of a window where we can sort of give them a little bit of extra support whilst they're seeking a review within the hospital, and we'll talk about escalation plans later. So it's a kind of ongoing process, as we're all familiar with, of trying to sort of optimise the settings, optimise the time off support, so we've got a nice stable child to discharge home. And we evaluate that in a variety of ways, whether bedside assessments, blood gases, sleep study, but I think also those kind of the general trend of stability. So is the child growing and developing better in an appropriate way for their condition? And, how frequently are they picking up infections and sort of requiring big changes in ventilation? And I think that kind of evaluation is a very MDT, it should be a very sort of MDT focused way of assessing things, because the different professionals are involved and we'll see different aspects of how a child is managing, and that all feeds in to try and stabilise them. So in terms of MDT, while we're stabilising the child, it's obviously also really important that we ensure that they have a stable airway clearance plan. So for some of these children, airway clearance isn't an issue at all, but for others, there's quite a large routine involved in ensuring that they can clear secretions effectively. So where necessary, they should have a very sort of clear plan about how to deliver the airway clearance at home, and that should be, the carers and family should be well trained and well versed in how to provide that. And again, it's looking at what might change when the child becomes unwell and how can we support them to escalate airway clearance in the home before having to attend hospital. In terms of other factors to think about when you're trying to stabilise them from a clinical point of view, infection risk is really important. So the basics of making sure that everybody knows how to keep equipment clean and maintain it well in the home. But that's also looking at understanding the child's infection profile. Do they need anything in the way of antibiotic prophylaxis? How easy can they access antibiotics quickly when at the first sign of coughs and colds, so that again we can intervene early, and those are all things that need to be planned out whilst we're getting the child ready. Nutrition, very important. We need to ensure that they've got a safe feeding route before they go home to minimise the risk of aspiration when they're on positive pressure, and also, as I said, to make sure that they're gaining weight appropriately. And the dietetic team are working very closely to sort of optimise that and make sure that caregivers are very clear about the processes at home. And lastly, neurodevelopment. I think it's really important that, you know, we don't underestimate the importance of movement in these children, and encouraging them to have more sort of core strength and able to, you know, progress to sitting where possible. All of these things feed into their respiratory function as well, and it really does need to be a team approach to kind of get the child on the right trajectory and make sure that that's then fed on so that the progress continues when they get home. So that's a whistle-stop sort of tour of some of the considerations from a clinical point of view on the things that we're trying to sort of tidy up before the child goes home. And I think we all keep in mind the fact that in some ways hospital is a safer environment for these children. There's emergency equipment and there are skilled professionals around, but there are so many benefits to being in the home. The psychosocial benefits, the benefits in terms of neurodevelopment for a child, and also probably the, you know, being out of a hospital setting from an infection risk point of view. But we are also aware that bed availability is an issue, and the right place for a stable child on technological support is to be in the home. But we're always having to sort of balance that up against the risks that we're aware of, so that we are comfortable that this is a reasonable situation to send them home, and we put measures in place. So I'm going to switch topics slightly now and cover some of the key steps along the discharge planning process. So this little roadmap is just to give an indication of some of the key steps. If we start on the left-hand side of the map, that's more about what's happening with the child as we're getting them ready for home. So we've talked about establishing the best airway or interface, switching to portable ventilation, and then from as early as possible, depending on their stability, the parents are increasingly involved in cares and encouraged to sort of observe and take part, and the training process begins. And that can take that can take as long as it needs to, but the earlier you start, you're getting ahead of the other steps on the other side. There'll be a regular process of MDT meetings where everybody gets together to sort of review progress with the plans for getting home, to do that in partnership with the families, and also to anticipate obstacles and next steps that need to be put in place to make it as smooth a process as possible. And then hopefully once all these things are on the other side, on the right hand side, are in place, then the child will start to transition to the home setting, and then hopefully move to being in the home with their family again. So this is the bit that will vary from country to country, but there are some sort of key steps in terms of the discharge planning that those working in this area will be all too familiar with. So it's very important that as a hospital team, we recognise children that may go home a complex discharge on long-term ventilation, so that we can very early on flag those to our community colleagues. We need their expertise to carry out a full sort of health needs assessment to identify what support might be appropriate for this child and family in community. Again, with that early sort of flagging of a child that may go home on support, we need to get a good idea of what their home environment is like. And there are good screening tools out there. but ultimately what is most helpful is if there's an expert OT colleague who can assess the home environment, and they will have the expertise to assess what might be an issue, both in terms of the setup and where the child will be, how carers will work in that environment, access, all of those things, but also to look at workarounds, because it may not be an ideal home setup, but is it a setup that can be adapted in some way to make it functional for the child going home and their family. If that's not the case, then they will need to look at alternative housing, and that can be quite a lengthy process, but it's obviously sometimes needed. Once that health needs assessment is completed, that in the UK, that's taken to a panel where decisions are made around the funding for the care package and equipment, and the process of identifying who the employed caregivers will be to support that family at home. Once they are employed or in place, then similar to the family, they need to go through an appropriate training process to ensure that they're fully capable and confident to look after this child at home. At the same time, the equipment's being ordered. And then once everything is placed, everybody is working together to look at that staged discharge and to sort of make arrangements for how to support the child when at home. So discharge coordinators could talk about this in depth for a very long time, but that's just an overview of some of the key steps. And I think you can probably already see that there's lots of different things going on at the same time. And so it's really important that someone's leading that process, whether that's discharge coordinator or whoever is nominated within your organisation. So they are setting clear timeframes and they're reviewing things against those, and also pulling everyone together to identify any obstacles or barriers to discharge and trying to sort of address those as early as possible. So I'm just going to focus on a couple of the key themes in terms of the discharge planning process, because we don't have time for them all. And certainly for clinicians supporting children on ventilation, training is a big component of our roles. It's of varying complexity depending on the child's underlying needs, but it's really important that as a whole we look at we carry out a training analysis to see what that family and child need in terms of training, and also those employed carers that are going to be part of their package. So it's really important that it's a comprehensive, competency-based training approach to ensure that we're very clear that if that we have seen a caregiver demonstrate appropriate skills and has a clear understanding of what is required. But that's easier said than done. The child might be fluctuating in terms of their stability, so opportunities for families and carers to practice some of those skills can be limited early on. But also we all learn in different ways, so it's ensuring that we incorporate a range of learning styles, whether that's sort of visual, practical, written resources to make sure that that's kind of a safe, supported process. And for a family, it must be incredibly daunting to take on these skills. They must come with their own sort of motivational and psychological factors that feed into the training and education. But again, it's about starting early and having a standardized process. There's lots of good guidance around what should be incorporated within training. And this is just to sort of flag one example that we use in the Southeast of a snapshot from our training documents that we work with families and caregivers. I'm sure a lot of you have seen this, but I would direct you to some really good resources on the Well Child website in the UK. And these 11 principles of better training sort of cover all the essential elements of what needs to be part of that kind of education and training approach. So running through the whole planning process for getting a child home, risk management is absolutely integral. So just taking this as an example, Kuhn et al. In 2010 looked at a sort of, I think about 200 patients that were on children that were tracheostomy ventilated at home. And over a 5-year course, about a fifth of those passed away. Predominantly that was because of their primary underlying respiratory illness, but there was also a large component that had emergency events in the home, so tracheostomy bleeds, tracheostomy obstructions, and other accidents. And from this study, this was a qualitative analysis of interviews with families that have made this journey. And this describes some of the other issues along the ventilator side in terms of things that happen in the home that are emergencies. And I think that's what we're constantly trying to preempt and make sure we have in place a good process so that we minimize anything dangerous happening and they've got a good backup plan in place. So with that in mind, with all of our planning, it's really important that we sort of put things in place properly. So monitoring is an important consideration. Depends on the child's individual needs. I feel like I've said that a lot, but we can't emphasize it too much. But at the very least, then for these more complex children, they will have a pulse oximeter that they use. For others, there may be some CO2 monitoring in some of the CCHS population. But whatever the monitoring is, it's really important that the parameters are set appropriately and the caregivers are fully versed in how to use it and how to respond to it if it's outside of normal range. Thinking about the emergency equipment that children should have in the home, bag valve masks, resuscitation bags, emergency oxygen suction equipment, backup suction equipment, and their tracheostomy emergency kit, and having a spare. I think the families that have got used to this and have lived this at home are very keen to always have an extra one of everything, just so that they know that, you know, on a bank holiday weekend, they've got something that they can put together and make sure it's a safe setup. But we're thinking about what happens if the power supply goes down, and you know, ensuring that their external battery supply is appropriate and that they're linked with the electricity boards so that they're put back on supply as soon as possible. And I've already talked about the sort of servicing and call out arrangements around equipment that they have. So I think all teams use some form of escalation plan, as in this region is called a respiratory action plan. But what we want to do is give families and carers the confidence to identify when there's a change in clinical status for the child they're looking after at home and to know what to do. So all the teams in some form will provide some guidance that kind of details what little signs to look out for when the child's starting to look a little less well, and what action to take, whether that be to change the airway clearance or to switch to their unwell program on their ventilator, and most importantly, in most cases, to have a conversation with their supporting teams or to seek a local review, so that again is preempted early, and things can be put in place to minimise any deterioration. So all families should have some form of escalation plan that ideally they take with them if they go to the local ED. And I think increasingly that's becoming accessible in electronic form via portals and different passports that families can hold. We try to make aware local ambulance services and local EDs wherever possible as well, so that they can also be well versed in the best management for an individual child if they were to attend when unwell. So once we feel like the majority of things are in place, we have a suitable home environment and the equipment is in place, it's time to start making that step from hospital to home. And again, no one size fits all, but for those children that have been in hospital a very long time, it's a very big leap. So we start with trips around the hospital and getting familiar with the equipment, and very gradually the families and carers will start to move away from that. They may spend some time rooming in within the hospital, start to take trips outside of the hospital environment, and then eventually maybe go for day leave before a final discharge home. And that varies for a number of reasons, but kind of managing that process is really important to gain confidence, both for the family, but also to make sure that we troubleshoot things around equipment and facilities in the home. And then the final piece to mention is just around follow-up and support. So making sure that in our discharge planning, we've referred on to our colleagues. We've been working in partnership with them to make sure that there's a local community team that can support them well, but that they don't lose those links with their respiratory centre that has established them. There needs to be sort of good dialogue and easy ways to access with any question, because we want these families to be able to sort of contact us and sort of support them through quite a challenging process. And I think COVID has so helped with that. You know, there's so many virtual options now to drop into a family's home and sort of do ad hoc reviews as needed. And for children that don't travel very well, that have a lot of equipment, that's certainly added something to our armoury. But it's making plans around who will see them when they first go home, what will that first couple of days look like, and then how will we gradually continue the support and then step that down if they're sort of managing well. And in the longer term, as we said very early on, these children can sort of they can take very different paths long term depending on their underlying conditions. So it's really important that we have regular review points along the way to see the direction of travel from a respiratory point of view. I just wanted to touch on education for some of our older children. So again, ideally this would be part of the discharge planning. It needs to start early, because to get a child back into an educational setting, again, needs quite a sort of team approach and brings in a whole extra range of professionals from the education sector. So we need to start early and together look at the health needs that will be required in school, and also how those can be best addressed, because again, that's a whole separate issue about who needs training up, how they'll be supported in that different setting, and how that education team would escalate if the child was unwell. So I think once again, the key message running through this is to sort of start early and spread the net wide in terms of what might need to be considered to make it safe and sustainable. Lastly, but certainly not leastly, I just wanted to talk a little bit about the family's journey. We've discussed how important it is for us to be as open as possible and to be very clear about expectations, both about how long the journey to home might be, but also what that might look like when they're looking after their child at home. So clear communication and working together are really important, and that can be difficult because it's a very stressful situation for families and it's a very complex process. And we always have in mind how best we can support the whole family unit, whether that's considerations around respite, how we can support the extended family and how they can work together to assist the parents in some situations, and that care package, the employed caregivers, how is that going to sort of help keep everything together. Lots of families value peer support from other families, and some very much value psychological support depending on the journey that they're going through. And I think we can't underestimate the welfare support that's needed. There's a big financial burden, whether it be from having to change their home or move home to make this happen, to the constant travelling in and out of hospital. There's a whole range of implications, and it's really important we support the family, because what we don't want is for the child to go home and those stresses just to be left under the carpet and to then cause problems that mean the child can't be managed easily at home in the future. I found this article very interesting to read, so I would sort of direct you towards it. This was the qualitative analysis of interviews with families who have children on long-term ventilation, and they bring out these 5 themes to consider. Thinking about how families navigate having carers and nurses in their home. You know, it's very different to normal family setup, and they need to understand what that might look like, and there needs to be quite kind of open conversations about managing boundaries around carers and people living within your home to support your child. The challenges around coordinating coordinating the carers that are coming into your home, the vast amounts of equipment that you need to store and you need to keep tracks of stock on and things. And I think learning is a process. There were some really kind of nice quotes from families around they felt very supported through the learning process, but that can't fully prepare them for those unexpected things that happen in their home. And I think as teams, we're always constantly learning about that and thinking, how can we support them better, whether that's through using simulation more as we become more familiar with it, and just sort of making them familiar with those emergency situations so they, as much as possible, so that they have the tools to deal with those when they arise. And as we've said, setting expectations, which is really hard to do because things can change, but just being open about that and giving them a range of what might be reasonable for their journey to home. So again, I direct you to a really useful document that summarises some of the key sort of concepts around complex discharge, and our LTV population, the more complex ones, fit into that really very nicely. It can be difficult to navigate, but I think it's so rewarding when finally we get to the point where the child has transitioned to home and the family start to build that confidence and they start to sort of adjust to normal life at home and with all those benefits. So just to summarise, as those that work within this sort of area are very familiar with, it's important to start the process early. We have a lot of processes running in parallel, but you've got a sort of clinical optimization alongside all of that discharge planning. And it requires a very coordinated approach with regular reviews to identify issues. Very clear communication, both within professionals, with parents, and also once they're in the home, very clear plans about how to manage their care. And it very much does require a multidisciplinary team to work in partnership around the child and their family. So thank you for your time.
Thank you very much, Ruth, for an excellent presentation on a very interesting and challenging topic. We had quite some questions coming in the chat box during your presentation, covering different topics of your presentation. I'll try to bundle them a little bit and we'll try to answer as many of them as we can during the remaining time we have. Let's see, first there's a number of questions around, let's say, the ventilator and the application of the ventilatory strategy and so on. And one of them is if you ever consider mouthpiece ventilation.
Yeah, we don't have many children using mouthpiece ventilation at the moment, but I think we're probably missing an opportunity. I think in those, when we're talking about children and young people, I think there's probably a group of, particularly some of those teenagers with neuromuscular disease and things that we are missing an opportunity. And I think it should be considered. I don't know whether others do use that and have experience. I can see pitfalls in much younger children for obvious reasons in terms of reliance on its use. But I think those that are sort of in later teenage years, then it makes complete sense to think of that as an option when they're more dependent on NIV for some of the day, for sure.
Okay, thank you. You also mentioned the unwell settings or have dedicated settings when the patient is unwell. The question here is if you're using like a secondary profile on the ventilator for that, or if you teach caregivers or parents to change settings.
Yeah, so that's a very good question, which I should have covered, so thank you. Wherever possible, we like to keep the machines locked in the home. It adds to the governance that the carers only use sort of presets, prescribed settings, and there's less room for error. So yes, we would, if we were hoping to give a child an unwell program, we would aimed to select a ventilator that allowed us to pre-program, so that usually we had slightly higher IPAPs or whatever that child needed, but that was preset. So all the family or carers need to do is follow their plan and know when to switch to the pre-programmed settings. But yeah, wherever possible, locked.
Okay, yeah, makes sense. Also, in regards to ventilator settings and modes, is whether you ever use targeted volume modes, or like AVAPs or IVAPs or whatever the name on your particular ventilator is.
Yes, and I think that's something certainly here we've started to explore over recent years. Some of our CCHS patients use AVAPs type targeted modes, but also some of our other sort of complex neurodisability children, a few we've switched to target volume, and that has been quite helpful in sort of keeping them a little bit more stable at home. I guess one of the practical considerations about that is that if children, when they're unwell, are admitted to another centre, and again that's very different in different parts of the UK, but in London, for example, if an unwell child on target volume is admitted to their local centre, it's a little bit, people are less familiar with it, so it requires a little bit of sort of additional support and understanding about having a sort of IPAP range and things. But yes, in some situations it works very well.
Really good to hear. I think one more question around, let's call it the equipment, is about humidification. Are you using internal or external humidification for your patients under an IV? And do you ever use heated wire circuits?
So we use, for a lot of our nocturnal NIV patients, they're not all humidified, but those that have more of an issue with secretions, or if they feel it's helpful from a comfort point of view, then we will use humidification. Where possible, we'll use an inbuilt humidifier, depending on the machine that we have decided, depending on the ventilator we've decided to go with. But in some instances, we will also use heater wire ones. For example, some of the neuromuscular disease children that have quite a significant secretion load and struggle with thick secretions, on occasions will opt for heater wire systems with them. But it's a bit patient dependent. We'll opt for inbuilt humidification where they need it first, but we may try a sort of heater wire system if they have a particular issue with secretions.
Okay, and the latter would mainly be for your invasive ventilated patients then? Yeah.
Mainly for invasively ventilated, or some of those more dependent NIV patients with neuromuscular disease where secretions are difficult to manage. But yeah, largely the inbuilt humidifiers make that an easier process at home, and that would be our preference. For tracheostomy ventilation, we use a heater wire system to ensure that we've got a sort of thermostat in the system to avoid tracheal burns.
Thank you. I think that was what we have here, mainly as product-related and ventilator-related questions. More from a strategy perspective, do you ever consider permissive hypercapnia? Sorry.
Yeah, so I think that depends on the patient's underlying condition. So for that sort of ex-preterm population with chronic lung disease, then certainly they may be managed with permissive hypercapnia. Whereas if you've got a child with CCHS, then you're certainly not sort of targeting that higher CO2 range. So yes, in some cases where we're trying to protect the lungs but support adequately, but it depends on their underlying condition.
A number of questions also on the tracheostomy. And related to that, like how do you manage time off and weaning from tracheostomy to NIV with your patients?
In terms of the transition, as in switching them from tracheostomy to NIV?
I assume, yes.
Yeah.
Yes.
Yeah, that's always a bit of a challenge, isn't it? We tend to try and prepare the child before they come into hospital, and they often even have a sort of preparation admission, where we get them familiar with a face mask, with a smaller tracheostomy in situ. So in a similar way to how you would approach a new establishment for non-invasive ventilation, making sure that they're very comfortable with the interface, and that feeling of flow in their upper airway is quite alien to children that have been tracheostomized for a long time, as is managing secretions with airflow passing their upper airway in some instances. So lots of familiarization and trialing the non-invasive ventilation with a smaller tracheostomy in situ. But then the particularly difficult bit always, I think, is when you make the decision that it's time to switch from non-invasive, from tracheostomy to non-invasive ventilation. So you decannulate, but you're often trying to manage quite large stomal leaks at the same time as optimizing their non-invasive ventilation. And I think that phase just is quite challenging, and it's just about really sort of careful management of the stoma and titration of their NIV settings.
Thank you. A bit of a longer question. I think it's like 3 questions in one.
Okay, I'll try and, yeah.
Around the tracheostomy care also, is how often do you visualize the airway in a patient with a tracheostomy? First part of the question. Do you do all your tracheostomy changes at home? Second part of the question. And if not, what are the ones that are being done in hospital, as third part of the question?
Yeah. So question 1, I mean, our ENT colleagues' practice would be to visualize the airway at least annually, so that you're sort of looking out for any granulations or change in the airway integrity. But obviously, if there was an issue at another time, whether that be sort of granulations or bleeding, then they would be looking based on sort of a presentation. That was question 1. Question 2 was, remind me.
Do you do all your tracheostomy changes at home?
Yes, so once a child is transitioned to home, in younger children, certainly there tend to be single lumen tubes, and mostly those changes are done at home. The ones that we would bring them into hospital to do are usually if there's an upsize where we want to sort of evaluate a change in size or a change in type of tracheostomy. And then our practice here is to do that in a hospital setting, so that can be closely evaluated.
Excellent, thank you. 2 more questions. I think 2 last questions we'll address here. There are more like from an organizational perspective, I would say.
Okay.
One is, what do you do if the family says that they will do and take care, all the care and take care about the kid, but the child is highly complex and you have concerns about it?
Yeah, I think that's a difficult one, and I think probably all teams have experienced that. It's tricky. I think we'd always try to start from a place of understanding about where they're at and how they think they will manage those situations, and also making sure that we are happy that the family fully understand what is required to look after their child at home. And sometimes bringing in another family to talk to them about the realities of that can be helpful. So I think we'd always start with a sort of more discussion and more dialogue to try and come to an understanding about that. But I think we also accept that families have different perspectives, and for some families they do very much feel that they don't want people in their house, and they feel that they can make that a safe setup. And I think what it comes down to is, as a team, do we feel that is a reasonable level of risk, or do we feel that's putting the child at added risk by not having the support of a care team around? And in those situations, then we would always sort of be involving our safeguarding team to sort of work with us to ensure we came to a conclusion where the child was safe. Most of the time, you know, you can sort of negotiate that, or you can often agree that they maybe will start with a care package for the first month to facilitate that transition, with the understanding that once they've taken their trainer wheels off, they could reduce that. So again, a lot of negotiation, but the hard line is if we don't feel it's safe, then that's a safeguarding concern.
Makes sense. Last question, which is a topic which I think you have not touched on, but I think it's a very real life question, is how do you manage the turnover of your staff with regards to training?
Yeah, I think it is really important to make sure that if we're training patients and training families, that we all keep our skills up to date. So that's about having standardized competencies and making sure that we use every opportunity to Have I disappeared?
All fine. No,
Have I
all fine,
disappeared?
all fine.
Oh, something very strange
You're
happened
still
there. Yeah.
Yeah, no problem.
It is a challenge, but I think we use standardized training and competencies to make sure that new staff coming in are trained to a consistent level, and we have to use a range of resources that are available to us to make sure that they are trained appropriately. You can't replace sort of experience with patients and sort of support in a clinical setting, but also accessing resources online and courses and conferences to make sure that we train new staff and we all keep our skills and knowledge up to date.
Okay, thank you very much. This was the last question we got here on the chat. So I would like to thank you very much, Ruth, for this interesting presentation on the transition of children with a ventilator to their home environment.